welcome to the next episode in season one of RHC Medicare Telehealth Part A billing. If you haven't already gone down to Best Buy and got the full DVD set, this will just be adding one more to that set. Unfortunately, we've met way too many times in the last few weeks regarding this issue, and this is one more time. Hopefully this will be the last time. We do want to thank Azalea Health and ChartSpan for helping us to put these on free of charge. We appreciate their sponsorship very much. My name is Mark Lynn. I'm a CPA from Chattanooga. I'm an RHC consultant. I've worked at the RHC program now for some 30-something years. Danny Gilbert is a RHC consultant who hasn't worked with the RHC program for some 30-something years, but she will be one of our panelists and will be handling the questions and information behind the scenes there. So if you have issues there, Danny will be taking care of that and keeping this train on its tracks, hopefully. If you've not become a member of the Rural Health Clinic Information Group, please do so. We've grown from 850 members pre-COVID to almost 1,600 post-COVID, or I guess during COVID now. So, and we do want to thank all the contributors to the RHC Information Group. A lot of the people that will be speaking today, they've worked tirelessly for RHCs during this time by answering questions on the NARHC listserv, on all the different state associations, and by answering them on the Rural Health Clinic Information Exchange and helping people to understand the chaos that we're going through. There is the services that healthcare business specialists provides. I won't spend a lot of time on that because that'll sound too advertising, but but there is the slide just in case. If you are looking for the recording of this webinar, it is being recorded. If you have an issue with that, please feel free to log off at this time, but we are recording it. I don't know if it's like the other ones. I don't know how effective it is to actually record it because it will probably be out of date in about 2 or 3 more days from now, but we are going to record it just for the sake of doing so. That recording will be, there will be a link to it at ruralhealthclinic.com, COVID-19. Your presentations will be there as well from Nathan, Patty, and all those 3 presentations are over in your handouts right now. If you want to get a hold of them there, we did send out the presentations this morning to some of you guys. Google Mail got angry with me for sending out too many emails and stopped letting me do that at some point in the morning. So some of you may not have gotten that. I'm shocked that they would be upset for me for that, but they did. So that's where that's that. Disclaimer: all this stuff is brand new. It just came out yesterday. Some of your questions we may not be able to answer. Some of them we may have different answers, and that's okay because we're learning this. None of us have a playbook for dealing with a pandemic. The last time I was in one in 1918, things were just a little bit different back then. But this one is a lot different than that one a few years ago. If you do have questions, wait till the end till all the presenters have talked, because we've learned this from Nathan from the NARHC's presentations and from our presentations in the past, is you're just going to fill up that question box and it's going to have 200 questions in it, and you're not going to get your questions answered. So wait till the end of the session, and then if you still don't have an answer, then please ask that question, and we will have a little bit of time at the end of the session to try to answer things that you're still confused about. Here is the agenda. I'm a little bit long-winded here. I'm taking up more than about 5 minutes. Ellen Knowles from Azalea Health will be on just in a second with a sponsor message. She'll spend about 2 minutes on that. And then I will introduce the speakers. Then Nathan will come on and do his Washington update. That should take 10, 15 minutes or so. Then Charles James and Shannon Chambers and I will go through hopefully about 20 minutes or so on this revised SC 2016. And I will stop in certain sections there for panelists to comment or to help us as we have questions as we go through there. Patty Harper will come on at about 12:45 and go over some documentation and some things like that. And then Julie will be here from HSA to do about 10-15 minutes or so on cost reporting. And then Douglas Swartz is with us. He's one of the co-founders of Azalea. He will be a panelist with us as well when he gets online. So Azalea, Ellen, or I think, and I see Douglas is here as well. So if you guys want to spend a couple minutes telling us about Azalea, this is the time to do it.
All right. Thank you, Mark. Hello, everyone, and happy Friday. I'm Ellen Knowles. I am the Marketing Communications Manager at Azalea Health. We work with rural health clinics across the U.S., and we really work to provide them with simple and affordable solutions to help keep you all connected to your patients, especially during this time of the COVID-19 pandemic. So I wanted to share that Azalea has a fully integrated and secure telehealth platform. Currently, for all of our Azalea clients, they have full access to that telehealth platform free. And for any RHCs of you on the line today, if you're in the market for a new EHR with telehealth functionality, we're also providing that free to you for a full year. And then for any practices who want to stick with your current EHR provider and are just looking to add a telehealth solution as part of your current platform, we also have a solution like that for you within our remote patient care suite. So we have a lot of different solutions, and if you're interested in learning about any of those, just let myself or Mark know following today's webinar and we can get in touch with you. As Mark mentioned, we also have our co-founder and vice president of revenue cycle management at Azalea, Doug Swords, on the line, and he will help towards the end of today's presentation answering any of your questions regarding telehealth billing and any of those ongoing guidelines and changes. So thank you so much, Mark, for letting us be a part of today's presentation and for all of the help and guidance you're providing. I'll go ahead and pass it back to you.
Okay, Ellen, thank you very much. And I think we do need to re-talk about this sponsorship deal. I had no idea it was going to be doing so many of these things here. So I'm teasing you. But thank you very much to Azalea and ChargeSpan for sponsoring these. Hopefully we won't do as many of these in the future, and we can actually get back to doing seminars and talking to each other face to face, because that tends to work better for me. Panelists and speakers here. Like I said, we have a great lineup of people that really know the RHC stuff. When you see my presentation, you're going to see something in purple is going to be panelist questions will show up on there. Those are questions you guys have asked me or asked on the RHC information group. A lot of them are a little bit harder ones that I didn't really know the answer to. So I'm hoping the panelists will help me and help you to understand that. So panelists, whenever we get to the stuff that's in purple, that means I'm going to stop and say you guys can talk, and remember to turn your mic on when you start doing that, because that's we won't hear you unless you turn your mic on. So our first speaker is going to be Nathan Baugh. He is the Director of Government Affairs for the NARHC. Nathan is from San Diego, has worked with the NARHC for 5 years now, and I think he worked as an intern as well. He is newly engaged, and he is working super hard for rural health clinics. I know we've had many late night email exchanges and Sunday nights and weekends, and so Nathan is working supporting RHCs and has really some fantastic news about the telephone visits. So we want him to take a victory lap, because victory laps are very, very rare in the rural health market, it seems like. Of course, Patty Harper with InquiSeq, and they have and her and Jeff have this product called InquiDocs. It's just fantastic as far as policies and procedures go. So I always highly recommend people to use that. That's a full-blown compliance system for you guys, and it's very, for what you get, it is very inexpensive. It's very, very fairly priced. So Patty is, I mean, she's just a wealth of knowledge. So cum laude, that does not surprise me. She's very, very smart, and a lot of questions I get, I refer them over to Patty because she is so good with that. And of course, Shannon Chambers, and Shannon knows all the billing and coding stuff. I listened to a webinar from her the other day. It was fantastic as well. And she's been with the South Carolina Office of Rural Health, I guess, ever since Marshall Mars, even before Marshall Mars left there. So it's been a few years, and has been working really strongly in the rural health clinic market. Although rumor has it she's not the greatest Uno player in the world. So we'll let her address that as well. And then Charles James, Charles was on here last time. He's done a lot of the billing presentations for the NARHC, and he is a wealth of knowledge as far as billing for rural health clinic goes, and FQHCs, and sort of a jack of all trades as far as knowing about the rural market and about billing, and they have a billing company. So Charles will step in and help me when I go in the weeds on the billing piece as well. Julie Quinn, everybody knows Julie from all the way back with Riverbend, and now she is with HSA. She is the director of vice president of cost reporting and provider education. You've seen her at the different NARHC meetings and state meetings, and traveling all over the country supporting rural health clinics. So we appreciate Julie, and she'll be on as far as the cost reporting session at the very end of this, and we'll go about 10 or 15 minutes of that. And Doug Swartz, he is in charge. He's one of the co-founders and the vice president of Azalea. He does the revenue cycle management for them. So he's going to be in the details and in the weeds as far as the back end billing cycle, and that will be a great addition to our panelists, because some of these things, like I said, I don't really go into the details of that. I'm more of a cost report person. I know the billing rules enough to be sort of dangerous. So Doug will help us fill in any gaps that we miss. And so now it's a time where it is Nathan's turn. I am going to turn over I'm going to make Nathan the person who's going to show his screen. And Nathan, you are now in charge. So we should be able to see your screen.
All right. Thank you, Mark. And I assume folks can see my screen now. I'm expanding it. We good?
Can. It's good.
All right, perfect. So thanks again to Mark for putting on these webinars and giving everyone a chance to talk to the Rural Health Clinics community. I am going to be talking about big picture, where the telehealth payment policy is, and what we like, what we don't like, and where we would like to see it go. And then the rest of the presentations will be getting into the details of the current policy and things like that. So I think the place to start is just for folks to understand what the current logic is for our fee-for-service peers. So if you're not in a rural health clinic or a FQHC, the way that telehealth works is got a pretty straightforward logic. And this is actually a quote from the Social Security Act, which is the statute. And basically what it says is that whatever service the physician or practitioner provides through telehealth should be paid the same as if that service was provided in person, right? So there's essentially no difference between their payment between an in-person visit and a telehealth visit. They, use a modifier to indicate that it was done via telehealth, but that doesn't affect their payment at all. So that's the logic that, dominates Medicare payment for our fee-for-service peers. In the rural health clinic, we have an incredibly different payment logic that was put into law in the CARES Act, which is phase 3 of the COVID-19 legislation. And our logic is essentially to take 190 plus different CPT codes used on the fee schedule, take the average of that to create a single payment rate for RHCs. completely different. So we'll do one of the 190 different services, and we get paid the average of the 190. So a very different payment logic, and one that is, in my opinion, not necessarily beneficial for most rural health clinics, and has a lot of long-term problems. And telehealth policy has moved leaps and bounds in the last couple of months as a result of the pandemic, and it's got a lot of room or a lot of way to go, because I do not think that these temporary measures are going to be the permanent measures going forward. As the public health emergency unwinds, whenever that may be, we're going to have to figure out what we are keeping, what we're changing, and what is going back to a pre-COVID-19 policy. So I think there's going to be more changes to come. So what is bad about the current telehealth policy for rural health clinics? The most obvious one is that payment for our uncapped RHCs, which is most RHCs, will be below what you're going to make in person. So the all-inclusive rate, average all-inclusive rate for our uncapped RHCs is in the range of about $220 plus. And obviously for telehealth, we're only going to be paid $92. So that's a big negative about the current telehealth policy. What this does is it disincentivizes telehealth and provider-based RHCs. You make more money if the patient comes in person, so you're going to encourage the patient to come in person. And it's certainly not the policy that we want to lock in place forevermore. Our fee-for-service peers, if you'll recall their logic, it doesn't matter whether the visit is in person or through telehealth, they're going to make the same amount of money. So they're able to utilize telehealth without any financial considerations. For our uncapped RHCs, every patient that you push into a telehealth visit, you're really hurting your revenue. So that's obviously a major problem with the current telehealth policy. We have the complicating factor of the fact that the time and costs associated with the telehealth visits does not count for the RHC's I should have said all-inclusive rate. It does go on the cost report, but in the non-RHC cost section, we'll get into that later. But obviously that's a major. It causes a lot of accounting headaches. There's FTE considerations, there's productivity standard considerations, and all of that is just complicating and doesn't mesh well with our all-inclusive rate payment structure. And another problem with this is that our claims data is going to be entirely inaccurate, because instead of filing the code that most approximates the visit and the service provided, we're going to be filing this G2025 code for everything. So we really have no idea what service was provided. It's just one of the 190 plus services on that list was provided, but the government and from a data perspective, we have no idea which of those services was provided. This basically makes reporting for quality programs extremely difficult. I've already had questions from folks that are in ACOs that need to keep track of the annual wellness visits that they're doing. They want to know how do they get their annual wellness visits that they provide through telehealth counted towards their ACO if they're not billing the annual wellness visit code. So again, it makes quality reporting, which is long-term where healthcare is going, and makes it very difficult if we have inaccurate claims data. So those are just a few of the problems with the current telehealth policy that I think we need to address long term. Admittedly, there are some nice things about the current telehealth policy. Most recently, as of yesterday, we learned that the audio-only visits will now be paid to $92.03. Previously, I was telling people to bill this as G0071, but that was really a patchwork Band-Aid solution to get paid something. Now, however, they are including that in the G2025 code, so you'll be able to get paid that $92 for an audio-only visit. That's pretty nice. Obviously, the $92.03 for independent RHCs is more than what you make in person. So they have the reverse incentive of our uncapped RHCs. Independent RHCs are incentivized to do as much as they can through telehealth. No, don't come in for that. Let's do it via telehealth. They have that financial incentive. Now, it's only about $6, but nevertheless, independent RHCs make more than they would in person. This underscores the fact that our rural health clinic cap or upper payment limit is extraordinarily low. And I'll get to that in just a second. But again, that is another nice component to the way that this has been set up. And then the other thing that you can look at it as a nice thing about the current telehealth policy, but I think once folks, I think that this will absolutely change long term. But clinicians that are not considered RHC practitioners traditionally can, and therefore cannot bill in-person encounters. They can bill these G2025 services through telehealth and be paid that $92. And the one of the examples that we use is a registered nurse performing a 99211 service, a level 1 established patient E&M. That is now something that you can bill through telehealth and get paid the $92.03. If that same service was performed in person, that would not be a billable RHC visit. So there are some nice things about the current telehealth policy, but to be quite frank, I think that the government will ratchet down on some of these things, and potentially, certainly when they make whatever changes they're going to make, I don't think that this component to the telehealth policy is going to be the long-lasting or survive COVID-19. Just because I can see the way that this might be abused, where you put a bunch of RNs into an RHC and have them bill telehealth distance site visits, get paid $92, and it's a whole sort of business scheme. I think that is going to be prohibited some way or another by CMS long term. So what we are hoping to do sort of most immediately is that we are going to make a phase 4 push in whatever they do for phase 4 to do two things. We're going to, one, try to raise the cap to $92.03 so that it matches our payment for telehealth. And our independent RHCs are not hurt by the second thing that we're trying to do, which is pay RHCs their all-inclusive rate. And we'll throw FQHCs into this legislation as well, their normal rate for telehealth visits. If we're successful with this, this means that if we get it done before July, this means we won't have that recoupment and all that craziness that we're going to talk about in just a second. So this is something that we're trying to push for in phase 4. I've spoken with Hill's staff, and I believe we're going to introduce legislation that is a 2-section legislation, very, very simple, maybe 1 to 2 pages, that is going to be introduced hopefully next week. and it's something to point to, and we are trying to rally as much support behind it so that those provisions can be included in whatever the big phase 4 package is or some other package that emerges. And again, hopefully we would get this done before July 1, so the recoupment would not happen. Again, we wanted to raise the cap to $92.03 because if we just paid RHCs their normal rate for a telehealth visit, we would be hurting all the independent RHCs because the independent RHCs actually do benefit from the telehealth payment being above the cap. So that's why we wanted to make sure that at a minimum we're keeping our independent RHCs whole, and that their cap would be raised to $92.03, and that would be for all visits, not just telehealth. So when this legislation is introduced, again, hopefully next week, we will need the RHC community to advocate for this and push this. It should be relatively simple to pay for or to explain to your legislators. We'll have more talking points on our website when this does come out, but the easiest one to explain is I'm not getting paid my normal rate, but CMS is paying me my normal rate currently, and they're going to ask to take all this money back in July. And that's ridiculous. At a time of a pandemic, you're going to ask me to owe money back to Medicare because they can't pay me my normal rate. So I think it's a relatively straightforward argument, and hopefully we can get it done before July 1. And with that, that is the end of my presentation. So I'm going to pull this up and toss it back to you, Mark.
Okay, Nathan, thank you very much. That sounds all very exciting. Hopefully we can get those changes that you talked about implemented and start getting paid an increased reimbursement rate. That would be fantastic. Okay, can everybody see my screen now? Anybody?
Yep, I see it.
Okay, got it. Okay, thank you, Nathan. Okay, let's go ahead and get into the second section here of our presentations. Again, my name is Mark Lynn, and this is the revised RHC Medicare telehealth billing guidance for this week. Stay tuned for next week's. And this has been so complicated, ever-changing laws, regulations, conflicting dates. Our first panelist question is, should drinking now be allowed on the job? Is anybody have any comments on that one?
I'll go ahead and take this one, Mark. The answer is yes.
It's 5 o'clock somewhere. Yes, this is maddening. It really is. But don't shoot us the messengers. We were dealt this hand of cards, and we have to play those. I know Shannon got a little bit of flack yesterday from somebody that was upset about this, and I hear people all the time talking about how confusing it is. And if you look at the Facebook group, it's very funny because the memes and the people are getting very frustrated with this. So, any other comments from our panelists there about the frustration with this?
No comment.
Okay, all right, we'll move on. First thing we're going to do is a view from 30,000 feet. This is going to be stuff that I know very, very little about, but just stuff that I thought we have a lot of provider-based RHCs in here that would really, they've been asking for it. If you ever listen to those office hours sessions, they're 5 o'clock to 6 o'clock every Tuesday and Thursday, and it's a place for you guys to ask questions. You got to get in really early and hit *1 almost as soon as you get into that session in order to ask a question, or you're going to get left out. But I noticed there was something was going on yesterday because I got an email from Lana Dennis early in the afternoon saying there's going to be no office hours this afternoon, and that led me something big was about to happen. And sure enough, CMS announced that afternoon the second round of sweeping changes for the healthcare system. And so definitely review that document there. It's relatively long. There's a lot of information in there. It relates to hospitals, policy, and telehealth. There is the the link that you can link into that and read that document if you've not seen it already. Some of the things it talked about was raising the telephone service visits on the Medicare Part B fee schedule to raising them from about $14 to $41 up to $46 to $110. That's on the Part B side. We also had the thing on the RHC side where we can actually do telephone visits as well. They added some piece in there where they can actually change regulations much faster than they did before, and I was having a hard time swimming with the current as it was. So things are gonna change any quicker. We're all gonna sink with regulations here. They sort of went back and recounted something about the distant site regulations as it effective March the 6th, and that made me sort of worry where they were headed with that. And you're gonna see this in a slide coming up just in a minute, and why that was a little bit of a concern to me. The next item, again, they added was what Nathan talked about was telephone visits. Now the CPT codes 99441 through 99443 can be paid at $92.03. That is fantastic for rural health clinics. I know we've been working closely with one of our clients in West Virginia. They're in southeastern West Virginia. They got 6 RHCs, and every time I go there, my cell phone does not work in those mountains. And it's absolutely stunningly beautiful. I'd love to go there, but don't think about getting audio and visual telephone service in that area. It's just not going to happen. So that's really a benefit to them. They have thousands and thousands of telephone visits that they can bill now. So that helps them. For hospital, Brock Schlabach, I've known Brock since he was administrator in Centerville Field Community Hospital. We set up a RHC for him 30 years ago. And so Brock is now with the National Rural Health Association. And from listening to those office hour sessions, everybody was in the hospital business was upset because on telehealth, they were missing out on the originating site money for that. And this piece of regulation allows now hospitals to get some originating site. It actually says that you can designate somebody's home as a temporary provider-based department of a hospital. So Julie, your home now can be a provider-based department of a hospital. I have no idea what that means or anything like that. You see it's in purple. So panelists, do y'all have any comments or any help with that? And we have Kate Hill, who's with the compliance team and is on the board of the RHC, and she's fantastic and very helpful. And so Kate, if you know anything about it, if anybody knows anything about this, please speak up, because I just told you everything I know.
This is Charles, and I don't have anything about this in particular. About the hospital piece of this, other than before we get into the nuts and bolts, and I'll keep my comment short, that back to a second ago, no comment. And I have to be a little bit careful when I say this. So Charles James, only as Charles James, but I think part of what we have been through is indicative of maybe where rural health clinics are on the priority list. Let's just be candid. And I think that it's indicative that often rural health clinics get left out of policy considerations. And I think it's also indicative that honestly, there's a little bit of a predisposition on policymakers against really cost-based reimbursement. And so I think that's part of what we suffer from on the rural health clinic side. And I think a lot of that is due to just a lot of misunderstanding about rural health clinics, and that it is more expensive for us to provide care in rural areas. And a lot of our transportation security that we experience with our Medicare beneficiaries this will enhance our ability to treat those patients. So back to Nathan's comments about the policy initiative that we really need to make next week, it is just imperative that our legislators understand the difference and that cost-based reimbursement isn't all bad. And here's who we are and what we are. And let's give one more plug to Elizabeth Ellis, a little tiny outpost rural health clinic that is going to be on 60 Minutes this Sunday. So please, everyone, watch 60 Minutes this Sunday for Elizabeth Ellis. She is physically not a large person. She's small but mighty, I say. So please watch that. And now I will. That's my comment. Thank you.
Okay, thank you, Charles. Anybody else want to tackle this one before we move on?
Yeah, I think that part of this is that we have to remember that anywhere that the provider is allowed. If they're at home, they can provide that. So while trying to read CMS language sometimes is, not that fun, I think sometimes we have to remember that those hospital providers, whether it's physical therapists or whatever, anytime that they're doing telehealth and they're at home, I think that's going to be caught up in some of this regulation right here.
Oh, that helps. That helps me to understand that. Thank you, Shannon. Okay. All right, people, we're going to move on then and go on to get into the RHC stuff. Well, almost to the RHC stuff. One thing from that document yesterday, at the very end of it, there was a nice, beautiful 2 tables there that talked about where COVID-19 testing could be done, doctors' offices, hospitals, homes, nursing homes, pharmacy, drive-through testing areas, and it gave some rates to be paid for that. And it looks like this one last item here, lab specimen collection from a patient. From listening to office hours, you really should listen to those. You will learn a lot about healthcare, things I didn't really know. That on there was that they were saying that hospitals were not able to get paid a collection fee for COVID-19, which I thought was crazy. They have to use PPE. They have the risk of catching it, and they were not able to get paid for that. And according to this new document, now they can get paid this $23 to $25. So panelists, y'all got anything on that? Because I just told you everything I know.
I would add that United Healthcare just released information out that they are also going to waive cost sharing for any of their members for the antibody test. That was released this morning. So that's just something in addition that they're going to waive that. So providers should see full payment for that.
Okay. All right. So anybody else have anything before we move on? Okay. All right. Those are things that are sort of off topic from real health things, but I thought they were important things that changed in the whole healthcare system. And here's one last one. A lot of administrators were worried if COVID-19 strikes their community and they went above 50 beds or more, they would lose their exemption from that horrible $86.31. Piggybacking off of what Charles said, is $86.31 is not cost-based reimbursement. It is a fee schedule. For all practical purposes, we do 175 cost reports every year, and we may have one independent RHCs. The cost per visit is not above $86.31 per visit. So we are not paid cost-based reimbursements for independent RHCs. We're paid basically a fee for service for that. And we're only 1.8% of all physician practices in the country. So that is one reason why we are swept aside and sort of on the bottom of the barrel as far as reimbursement goes. But for those administrators that are worried about if they went up 50 beds or more during COVID, during the PHE, they do not have to worry about that. They're going to use the number of available beds before they went into the PHE. So anybody have any comment on that before we move on and get into the real stuff that you're here for? Okay, we're good to go. We're going to move on that.
Mark,
So here's,
yes,
go ahead.
I do have one comment real quick.
Oh, Nathan, okay.
So I'm a big basketball fan, and Masai Ujiri is the GM of the Toronto Raptors, and people were the media kept perpetuating this notion that no one wants to play for Toronto. Well, Toronto is the reigning world champions, right? And the analogy here, and what he told the media before that season, he said, we need to stop this narrative. People do want to play for Toronto. And he pushed back strongly against this woe is me attitude that folks, the local media in Toronto had. And so I do want to push back a little bit on this attitude that rural health clinics are always the last in line. We need to push the narrative that we are important, we are getting attention. It's useful in a certain sense that, hey, you aren't giving us enough attention, but we can't play this victim card all the time, and we do have to recognize that the government is doing significant things for rural health clinics, perhaps not as much as we want, but there's this balance here that we have to achieve.
Fair enough. Acknowledged.
Yeah. And I must say, the things that CMS have done during this PhD, I've been in healthcare for 40 years. I've never seen the amount of work and the effort that these guys have put in there. They're like us. They're not perfect. There's some things they have missteps, but oh my goodness, what an effort they've made to help us.
Yes.
Yeah. Let me just, if I could just summarize that, it's more, our efforts will not be futile. We have not been completely ignored. We have been able to make positive changes. So efforts are not futile because we are just never thought of. We are thought of, perhaps not as much as we should, but our efforts to change policy are not futile.
Amen.
Okay, all right, let's move on. I think our
Mark,
discussion. Yes, go ahead.
This is Kate. Mark, let me just say one thing. So when you were I stepped away and got caught on that one, didn't I? But let me just say this about location. For telehealth, location is wide open. The location changes that were mentioned on the last go round are not meant to open a rural health clinic in the middle of downtown Chicago. They are meant with the intent, if your clinic is in the hospital building and you have COVID-19 patients, you want to move that clinic 3 blocks away or over to the MOB. That's fine. That's what they're saying. Or you want to split your clinic, keep half of it here for healthy, otherwise healthy, and over there for symptomatic. Or you want to see patients in the parking lot. That was the intent of that, not to start opening clinics in non-rural areas. Now, if that little piece of your clinic happens to fall out of a HPSA, then it's fine. It's still covered. But I'm getting calls like, oh, we're going to open a clinic over here. No, you're not. No, you're not. It's not meant for that. The purpose of it is to keep patients safe. And you have to do what you have to do that.
I think it's important. Thank you very much, Kate. That's an excellent point. I think it's also important that we, in our push, make sure that we have a good explanation on why we should be paid our encounter rate for a telehealth visit. And so I think that's something important that we have an answer for.
Okay, let's get moving on here because I'm gonna wheel into some other people's time here. So here's what yesterday there was a release of a document. It was called the SE 20016. It is a revised edition. It was the first edition came out on April the 17th, and then 13 days later out comes the new edition of it. Here's what it looks like, and there is the website where you can go to and read it. It's only 7 pages long. It was 4 pages before, and now it's up to 7 pages. And there is the information in yellow there that talks about what has changed. It put the information in red, so I'm going to screenshot some of the pages that are in there. So we'll get to that just in 1 second. One of the things that we ran into was all this backdating. Let's watch for examples. For example, RHCs can bill telehealth visits starting January 27, 2020, 2 months before the CARES Act was approved on March the 27th. That seems sort of strange to me, but okay, good. And then it also distant site. RHCs were allowed to be distant site providers. That was that rule. And then 39 days before, patient homes were allowed to be originating sites. That only came on March the 6th. And so there's some big differences there. Is a patient home can only be an originating site starting March the 6th, but an RHC can go back and bill to January 27th. I'm not sure about that. So those are some of the issues there. We'll talk about that as far as with our panelists here. Here's the screenshot of the information that was in yesterday's revised SE 20016. And my question is, okay, it tells us the law, CARES Act says we can go back to January 27th, but there's another piece of legislation or regulation that says that we can only go back to March 6th and have the home being a being a originating site for a telehealth visit. So my question is the panelists is, can we really go back to January 27th, or for all practical purposes, are we stuck going back to March the 6th as a distant site? So does anybody, Nathan or Charles or anybody, have any comments on that?
I think we're all a little hesitant to say, hey, if you were doing it in January and February before we were under an emergency, then you weren't really following the RHC guidelines at that point, what the federal rules and regulations were. There is where, you know, it was signed on originally March 27th, and then I did see the information back to March 6th, but I think I would probably have to send that one over to Nathan.
Yeah, I would agree with that. I mean, we don't know for sure what would happen if you build a claim from, let's say, January 27th and build it, let's say, G2025. Hopefully, I kind of think it's a moot point because probably that service wasn't happening on January 27th. So I don't, and so hopefully it's not really a big issue. But yeah, we don't really have clarity on what the backdating on this aspect means exactly. But hopefully you don't have many claims that are in this category.
Yeah, I wouldn't. Go ahead.
No, Mark, please, after you.
No, I was just going to say, yeah, I was thinking from a practical standpoint is March 6th would probably be the first date. If you actually just implemented it immediately as soon as you saw that, that would be from a practical standpoint, the first date you would be seeing claims going back that far. Charles, go ahead.
Well, I think we're going to have a couple different problems. So first of all, we've seen where we've billed a lot of our telephone only visits as virtual check-ins.
Yeah.
And we've had people do that. So what are we going to do with those? In my view, I think there's room to, everyone's going to have a conversation with their max. There's probably room to pay those back and then reprocess them back to March 6th as this G2025. That's probably a question for our max, but we're going to have a question about virtual check-ins that were telephone only visits. And I think this gives us the latitude to do that. I think that the other issue people have been having is that our max have been having some trouble with the virtual check-in codes with the CG modifier, and over the course of the past 10 days or so, those have been worked out, and either the MAC is going to go back and now this is only for erroneously bounced virtual check-ins, but the MAC would go back and reprocess those and pay those correctly, or if anyone speaks this language, DDE, you could F9 those claims and kind of get a return to provider claim sent back in. But then that brings me to the last point. Some of the MACs have been out front on this G2025 issue prior to the CMS announcement. So I think part of us, we're going to have to pay close attention to the particulars that our MACs give us. You know, Noridian could call for something marginally different maybe than NGS, who could call for something a little different maybe than Novitas. And I think that the MACs probably have, you know, that's their prerogative, as I understand it. They can have their own payment rules. So I think we need to be cognizant of those things. The virtual check-ins that we're going to need to really probably send in a corrected claim in some manner for those that were telephone only visits, those that were processed incorrectly by the MACs that were virtual check-ins and will be reprocessed automatically. We're going to have just some reprocessing of claims all over the place in this whole process, I'm afraid. So that's what the point I wanted to make.
Yeah, that, Charles, and that, I think that's going to come up in one of our slides in a few minutes here too. So we will talk about that exact issue as when we get to the telephone services there, because we coded, a lot of people were coding the G0071 they were really 99441s or 99442s, and they were billing them, and now they're like, oh no, I don't want to do that. I want to go back and I want the $92.03. Forget this $24.76. So there's going to be some issues there. So let's talk about, let's give a out with the old, in with the new. And so our April 17th guidance told us for Medicare telehealth claims from January 27th through June 30th, 2020. Here was our process: is in field locator 44 of the UB04, we put a listing. There was 191 telehealth codes that are CPT codes that you could bill as a telehealth visit. The things like 99213s, 99214s, your G0438, G0439, those were all in there. And so we were using that. And they also, CMS told us you need to put the CG modifier and the 95 modifier on there. Those were two mandatory modifiers in order for you to get paid, and your payment rate was going to be $92. You were going to get paid your all-inclusive rate. So if you were an independent RHC, you're going to get $86.31 will be paid at your rate. Or if you were provider-based and the mean average was $214, you were going to get that. And your payments would be reprocessed in July to sort of normalize those to this $92 rate. So if you're an independent RHC, you're going to get about $5 extra in July per telehealth visit. And if you're a provider-based RHC, they were going to whack you almost $100 if you had the average, the mean all-inclusive rate for a provider-based RHC. And it would all depend on what your actual interim reimbursement rate was from your MAC as far as being provider-based. So that was April 17th. That was the old. Now the new guidance that came out April 30th, it was very confusing because the MACs did get this information a couple days ahead of time and started telling people, and we were all complaining like, oh, they don't know what they're doing. Hey, why are they saying that? And then sure enough, this was announced yesterday that, oh, okay, they were just ahead of the game. So the CPT code now that you use, they've expanded that telehealth listing now to, it's a little bit over 200 and something telehealth codes that are out there. It's been expanded, but you're going to use the G2025. So any of those 200 and something HCPCS codes, you're going to use G2025. You are definitely going to have to use the CG modifier until June 30th. If you want to use the 95 modifier, if it works for your cost reporting, or it works for your internal systems of you wanting to know what were telehealth visits, then that's perfectly fine to use it. It's not supposed to reject your claim there, but your requirement is to do the CG modifier. If you do have and there's another modifier we'll talk about in a minute called a CS modifier. If you want to add that, that's a cost sharing modifier that will if it's related to COVID-19, then it will allow you to not collect that copay from the patient, and you will get your full all-inclusive rate, or the full $92.03 from Medicare for this telehealth visit. Notice the rate change from $92 to $92.03. So they had a little math error on the first one. Things will still be paid at the all-inclusive rate, and they will still be reprocessed from this April 30th guidance. So we have a couple of panelist questions here. Number one, is it still a good idea to keep that 95 modifier on there? Do you think it would help you maybe identify things on the cost report? That might be a Julie Quinn question there, or just better just to leave it off. Does anybody, any panelists have any questions, any comments on that?
I would put it on to track it. You know, if we're having a question of tracking, I think with this, we have a big question about how we're going to internally report our HCPCS codes, like you already said, Mark.
Yeah.
So I haven't discussed it yet with our billing staff and our billing team, but can't hurt for tracking.
Okay.
One of the things, Mark, that we...
Yeah, go ahead, Doug. I see you've opened up your line. Doug, go ahead.
This one has come up a lot with us. It's a billing service. We bill for a lot of independent and provider-based RHCs. And what we've been asking our providers to do, we've been creating a separate location and the definitions and naming it the telehealth location, and then putting all the telehealth visits on that. So that way, when you're running your reports, it's easier to carve out those visits. The trick is just remembering to use that location, but I think it was easier for us to do that than to try to remember the 95 modifier.
Oh, excellent, excellent. So if you have Azalea, then they have a built-in system to handle it one way, that whether you use a 95 modifier or not, that will work for you. And Julie, I see your line is your telephone is open, so go ahead and make your comment.
I did unmute myself. And everyone that knows me knows I'm just dangerous when it comes to the billing side. I look to these experts when it comes to how the billing information is going to come off for us to use for cost reporting. But as we get into the carve outs for cost report, we're going to have to come up with some mechanism, whether it's purely seeing how many G2025s you did, and then we can drill from there. But yes, we're going to have to be able to say we did this many telehealth visits. And then if we can drill further and say this many were level 2, level 3, that would be great. I'm just not sure that every system is going to have that capability.
Yeah.
In addition, I think that, so in addition, I would say that if your system, if your EHR, you can keep it as a 99212, 213, whichever. And then at the clearinghouse level, you can write a custom rule to get that to switch over to the G2025. You're going to be able to write clear billing or run report. How Azalea is doing it is fantastic. You're going to be able to run that by location. I think that's awesome. I think the thing that worries me that no one's brought up yet is if I do an annual wellness visit by telehealth now, you know, normally we can go into DDE and we can see when that patient's had their last telehealth or last annual wellness visit. None of that information is going to populate on the common working file with all of these screenings that we're doing by telehealth. So that's something else you're going to kind of want to think through is, you know, claims are going to be a little wonky. Let us get through this next year. You know, when you go to bill for your annual wellness, and hopefully we're all back in the office, of course, by then, it is going to be a little bit different. None of that screening stuff is going to show up on the common working file. So Patty, Charles, I don't know if you have other things, or Doug as part of that. That's just a concern that I have is how do we track that?
No, that's valid. That's
That's why I'm always a big fan. I liked when we got the new billing rule for rural health clinics, even though the qualifying visit is awkward, that we have to include our detail on the claims because we have to have some way to track it. That's a valid reason. I don't know that trick. I don't know how you're going to get the annual wellness visit on the common working file under this. So that's a mechanic we're going to have to work out in the future. But definitely, I say, however you can retain that actual detail on your system, but not submit it with the claim, you're going to be better off.
Yeah, I think that's a good point, Charles and Shannon, and everybody is excellent. I didn't even think about the common working file not being accurate with this G2025. So that's excellent. I would definitely want to make sure, if it was me, I'd probably put the 95 modifier, even if they do get scrubbed in the clearinghouse when they send them out. That way you do have that information that Julie and I will need to prepare that cost report, because we're going to figure out the time that you guys spent doing a G2025. Unless we drill down to that HCPCS code, we're not going to know if you spent 11 minutes, 20 minutes, or 30 minutes of provider time for whatever that G2025 telephone visit was. And that's going to make a difference on how much time we end up disallowing on the cost report. So let's move down to the next question, and because I'm sure we'll have some people commenting about this one. This just came in this morning saying that Palmetto isn't recognizing the new G2025 code. When will the MACs update their systems for the new CMS guidance? And concerning the previous telehealth guidance, telehealth claims billed, will those be reprocessed in accordance with the new G2025 guidance? And so I'm like, Julie, I know enough about billing to be almost dangerous. And so Doug or Charles or any of you folks that deal with billing all the time, do y'all have any comments on this particular panel's question?
So I actually reached out to Palmetto. Their main headquarters is located about 15 minutes from where I live. So I won't go show up there. Done it before. But I think that, we need some clarification. We need to know when their system is going to be modified. We've got some great contacts. I'm sure Nathan and Bill are also probably on that as well. I promise as soon as I get it, I'll share it with you. I've not seen anything. I asked questions specifically about reprocessing the claims versus us having to do claim adjustments if we filed a 99213 with the CG in 95. Per the prior information, how's that going to be handled? I also asked them to clarify if we had previously done a telephone call, how is that going to be handled as well? I just have not received. I sent that off yesterday afternoon late once I started seeing pretty quickly. And then one of the clinics that I work with notified me about it's not processing as well. So unfortunately, I don't have any other updates at this point with Palmetto.
Yeah. Well, Shannon, thank you for that. And I would think that it's only been out one day. So sounds like it's time for another webinar. Oh boy. whenever we get the final guidance on exactly what to do. Doug, Doug, do you have something to say? Your line was open there for a second. Do you have any comments?
No, I just think it's funny that we were talking earlier, the fact that they came back so quickly and said, never mind, we want you to use the G code. Told me, okay, well, maybe they figured out how to get it in their system. But no, if it's not ready to what's going on? I figured they needed to buy themselves time to get the code loaded so they could pay it. And that's why they said July 1st. And then maybe they turned around and figured out it was easier than they thought and said, all right, now we want you to use the G code. But then now we're not sure if they're going to be able to process it. I just found that funny.
Yeah, I thought the same thing. I was like, wait a minute. I thought it had to be July 1st before to get this thing loaded. And now all of a sudden, magically it works. Their story didn't sort of fit there as well. Nathan, I see your line is open. Did you have something to say too, or did you just leave it open?
Sorry, I just muted on my phone. That's why my line's open.
Oh, okay, gotcha. Okay, never mind. Okay, gotcha.
But
all right.
we don't have anything else. Other than I'll say that this is another reason why I would like this to change. I would like to be able to bill 99214 with just a modifier, get paid the all-inclusive rate, count it as a visit, count the cost on the cost report. That is the vision that I see long term, and I do not want the policy as it is currently to be the policy that gets locked in place forevermore. So just these are all reasons why we need to get it changed.
Okay, perfect. All right, let's move on. Here is just a screenshot of what was in the document that was sent out yesterday. You see everything in red is the items that changed. They're setting the rate to $92.03. They're using the revenue code is going to be a 52X if it's in if it was a telehealth visit that's normally in the office, that's going to be a 521. If it's in a nursing home, it could be either a 0524 or a 0525. If it's in an assisted living facility, that would have been a revenue code 0522. So those would be the revenue code you'd use. There's your HCPCS code. That's going to go in field locator 44 under UB04, the G2025. And then again, the CG is required, the 85 is optional. So that's just the source document where I generated that slide of the previous slide. And then here's what your claim form is going to look like. UB04, the ANSI 837, you're going to bill these on the UB04. You're going to use a bill type 0711. That's basically you're asking Medicare to pay. You have a payable visit and they want you to pay it. There's your revenue code we just talked about. Here's your HCPCS code. And here's the summary, the CG modifier. Possibly you could put the CS modifier on there if it's related to a COVID patient, and then the 95 is not required. What they told us was that the reason why you had to use the CG modifier until June the 30th was CMS was not going to update their system until July the 1st. And that's why you have to put this CG modifier. They're going to pay you at your all-inclusive rate until June the 30th. A lot of people ask us, what's the place of service code for place of service on the UB04? There is no place of service. It's this revenue code tells CMS where everything is going to be done. And The panelist input, will RHCs have to append or refile their claims already processed? I think Shannon's done a great job already explaining that we don't know yet. It's 15 miles away. She's going to run down to Palmetto, and we'll get an answer sometime next week, and she's going to share it with us on how to append or refile these claims. But that's something that's on our to-do list right now. Does anybody have any panelists have any questions or comments about this particular slide here before we move on?
No, I just want video of Shannon running.
Okay, yeah, that'll be good. If Shannon is running, there's somebody after her. That would be me right there. So,
No,
okay.
she's been running after bocce balls in her yard.
That's true too. That's true too.
Okay, so let's move on to after. Okay, so that's the guidance we just told you about got us through June the 30th. Thankfully, July 1st is going to be a little bit simpler. Nothing really changed there. Our guidance from April 17th said we're going to use G2025 in field locator 44 on the UB04. We don't have to put any modifiers on there. Our rate's going to be $92, and we're not going to have to reprocess the claims. Very, very simple process. April 30th comes about, and everything is exactly the same except for, we get a 3-cent raise. So it's going to be $92.03 versus $92. That is the only change affecting your claims after that. So here's the revised information. And this is the same information that we gave you when we did this webinar on April the 22nd. So there's no changes there. If you want to add the 95 modifier, it's not going to reject on you if you add that to it as well. So I think we should be pretty good on that one. That one, so nothing really changed on that. So question again, do we know what will happen to claims already submitted? That was a common question in the RHC information group today. So I copied and pasted it several times. The answer to that is we don't know the answer to that, whether it have to be appended, F9, or see, I'm learning stuff all the time with these things. So thank you, Charles. So we will have to do something. We just don't know what it is. And all these people are very good about communicating with you on what will happen. So we won't worry about that. We do have, and I'm gonna have to pick up my speed here. Here's some information from the revised. What I did was I had some T accounts and showed you how the billing would work. So let's do it real quickly. Here's our assumptions. We're going to charge $100 for a 99213. The all-inclusive rate for an independent RHC is $86.31. For a provider-based, we use the average rate from Wifley. Does these great benchmarking reports. So last one I saw had an average of $214 per visit, cost per visit. So I'm going to use that. Whether you're independent or provider based, you're going to have the same telehealth payment rate, $92.03. And what Nathan was saying for independent RHCs, we're like, yay, we get the telehealth rate. That's $6 more than we normally would have get. And provider based RHCs are going, boo. We get this. This is $97.57 less than what we normally get per telehealth visit. So we can see how that policy is not sustainable in the long run. So the copay, $20 is 20% of 100. That's what we're going to collect from the patient, unless it's related to COVID, and then you use the CS modifier. And let's go over here to what happens. The settlement calculation is we're going to use $69.05 as our payment from Medicare, because remember, you only get 80% of your rate from Medicare, and there's no sequestration during the PHE. So that 2% that they used to take out, that no longer applies for now. Now that's going to come back after the PHE is over, but for now you will get 80% of your rate. So that's why it looks, you get a few more dollars every visit. If you're provider based, that you're going to get $171.20 per visit based on 214, and as an independent RHC, you get $69.05 for every visit. That's, again, that is woefully low. It's falling behind. Okay, so our telehealth payment rate, they're still only going to pay you 80% of that. So when I say you get $92.03, you're not getting $92.03. You're getting $73.63 per telehealth visit. no matter if you're provider-based or independent. And what will happen is when CMS recoups this money in July, the typical, and again, I'm gonna say these are typical, these are not exact numbers, but a typical independent RHC is gonna get about $4.58 per telehealth visit back. And the typical provider-based RHC is gonna have a recoupment of $97.57. And what some provider-based RHCs have said, oh, that's gonna hurt when July comes around and they take all that money away from us. Can we hold our claims until July 1st and then submit all the G2025s at one time? And that way we won't get reprocessed, the claims won't get reprocessed and the money taken away from us. And you certainly, that is allowable to do that. There's timely filing issues that you have from Medicare, but that's 1 year from date of service, so that shouldn't affect you any. You may run into some timely filing issues on your secondary payer as well if you wait. And sometimes the secondary payers are very, very short timely filing issues. It could be 3 months, could be 6 months, it could be a year. So those are some of the issues you have. Panelists, do y'all want to weigh in on whether provider-based RHCs should hold their claims until July 1st, or just go ahead and build up a little bit of cash and then pay it whenever? It's sort of like an interest-free loan. I mean, if it was me, I would probably bill it and and pay it back. But go ahead, Charles.
I think a lot of our folks are going to be able to hold the claims. Yeah. I think for those that can do it, that's a great option. But a lot of them just, that's not an option. So of course, for those more at-risk sites, it's going to be more difficult to maintain the balance when those get reprocessed back. So that would be the negative, I think, of that. The other issue though towards holding on to them, if you look in the guidance, it's not an exact equivalent, but on our non-visit claims, so we have the ability to bill some non-visit, what would otherwise not be visits, especially in FQHCs. On the FQHC side, they've said expressly hold this volume of claims until July 1 and then bill them. So if you can weather that financially, it may not be a bad option.
Okay. Anybody else have anything on that before we move on? Okay. All right, I'm going to move on here, and here's our little T accounts here. Here's what using the revised guidance, and I moved my date back to March 6th just based on our conversation earlier. Here's what our G code is going to look like, the G2025. Now, this is from March the 6th and through June the 30th, and we're an independent RHC. Here's our field locator 44 G2025, and we're going to add the CG modifier to that. We're going to charge $100 for it. Our all-inclusive rate is going to be $86.31. And if you put this into our accounting system, we're going to have a charge $100. We're going to collect cash of $20 from the patient or their secondary insurance. Medicare is going to be nice enough to pay us $69.05, and we're going to write off $10.95 as a Medicare contractual adjustment. And then in July, when CMS comes in and our MAC reprocesses the claims, we should have a receivable of about $4.58 per claim, and our cash receipts will come in debit, and we're going to have a contractual adjustment of a negative contractual adjustment of $4.58, which is great. That means we reduce our contractual adjustment. So that was the things in red are the numbers that changed on that particular slide. And then if you're provider based, the same scenario, same field locator information there. The difference will be the $214 all-inclusive rate. If we only charged $100 for this charge, we actually would have what's called a negative contractual adjustment. We would receive more money than what we collected. That's always fun explaining to your patients why you collected more money than you charged, and you still want them to pay you $20 for that. And then of course, here's the bad news that we talked about, the recoupment coming in July, and we've already had our panelist input on that particular one as well. So let's see here. Here's a telehealth visit. Let's see, established patient occurring July 1 through the end of PHE. And then this is after July the 1st. This is the simple thing that we don't have to put the CG modifier in our field locator 44. That's going to be 2025. CMS, instead of paying us $92, they're going to pay us $92.03, and that's going to change our contractual adjustment and our payment just a little bit down here. But that's really going to be the only change from our last webinar that we had. This will be the big change in this webinar, the telephone visits here, and this is where we copied from. This is the screenshot from the document where they added the telehealth codes, the telephone calls. I'll get this right in a minute. The telephone calls here's if you click onto this document, which will be on the next page, that is that listing of 200 and something telehealth codes, and they added 99441, 99442, 99443 audio only, and we can bill those now as a G2025. So Pamela's question is, what about claims already submitted? Can we be refiled, refiled, sorry about that typo, refiled as corrected claims to get more reimbursement? So could we cancel all those G0711 claims and resubmit those as a G2025 and get moved from $24.76 to $92.03? And so I guess I'll open it one more time, and you guys can tell us. Charles, can you help us on that?
Just please point out, first of all, I don't want to take all the air. Somebody else can answer. The G0711 is not a thing. So we don't, to my knowledge, we don't have G0711 claims unless I'm misspeaking. So
what's it, G0511?
G0071.
Okay,
that's what we were referring to. So that may have come in as the question. And so 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 G0071, that was what I was referring to a couple slides ago, where to me it would be acceptable to repay our G007. Now I'm getting tongue tied on it. G0071 claims and have those resubmitted as correct. I'll let the billing people go with the occurrence code and corrected claims and 718s and 719s. But yes, refile those as a telehealth visit. I would think that would be perfectly acceptable. But it is G0071 that we would refile as G2025.
Oh yeah. Copy and paste sometimes gets you in trouble, doesn't it? So I apologize for that. I didn't notice the difference in that number there. But yeah, I mean, if it was me, what I would do is there's a bill type that you can use to cancel a claim. So if that claim is being held up, is cancel out all of those. I think it's 0717 or 718. There's a bill type that you can put in there, cancel that claim, and then resubmit it the way with their guidance. Is that what you do, Charles?
Yes, sir.
Okay, perfect.
Let me just, could I just chime in real quick?
Yeah, go ahead, Nathan.
It's important that you're only doing that for those claims that were the audio only telephone services. If you were billing G0071 because your provider had spent time going back and forth with the patient through the patient portal, those need to stay as G0071. So it's not a blanket statement.
Oh, yeah.
And keep in mind, that's an excellent point, Nathan. G0071, text counts, email counts, portal. Thank you, Patty. Portal, yes. So keep that in mind. So back when, and I retract, I don't want anyone to think I was disparaging anyone. All of the people that did heavy lifting on this is a great thing for us to have these telephone visits. So
Shannon, could you clarify, would we adjust those claims or cancel those claims? Do you have I didn't mean to put you on the spot.
No, you're good. I would say that I think that, I mean, if you cancel the claim, they're going to automatically pull the money back, and then you're going to have to reprocess. So even if you file like the corrected type of claim, to me, I would say canceling is going to make it nice and easy. They take their money back, we refile. But I was also going to make sure you're going to have to do something, because CMS does not know if it was a text, if it was an portal conversation back and forth, or if it was a phone call prior to the guidance they've released as of yesterday. So I think that's going to have to be a system process. But if it's me, I'd want to cancel the claims just so it comes back clean.
Okay, perfect. Okay, let's move on then. I think that we sort of have a plan there, and we will get some more guidance in the next week or so to let you guys know what to do with this. Here are the codes, the CPT codes 99441 through 99442. You can see the number of minutes, 5 to 10 minutes, 11 to 20 minutes, and 21 to 30 minutes. When you go over 30 minutes, then there's no more codes for you. For all practical purposes, for an RHC, once you hit 5 minutes of documented time, you're really hitting G2025 category. So you really are not getting compensated any more money as you go down this line. Of course, obviously, if the patient needs those services, you're going to do it. Make sure you timestamp your documentation. Patty will talk about that sort of information in her presentation next, but you can see it's extremely important that you timestamp your information, not only for Patty's sake as far as the billing goes, but for Julie and for myself on cost reporting as well, so we know how much time to disallow for that. So those are the HCPCS codes. Also, these telephone visits have the same sort of look back that you have for a virtual visit. If it's related to an established visit that occurred within 7 days, you're not going to be able to bill this telephone visit. Or if you have a telephone visit with the patient and you basically tell them, okay, come in at the next available appointment or within 24 hours, you're not going to be able to bill that telephone visit as well. So keep that in mind. Yes.
Hey, Mark, can I chime in? I got it from a very reliable source that we're better to adjust than cancel. Thought I'd throw that in there.
Okay. Adjust versus cancel. Okay. Okay. Very good. All right, let's move on then to the next one. Here is the listing of the telehealth services. If you click into this document here, you're going to get a Excel spreadsheet, and that Excel spreadsheet is going to look just like this. So they added this extra column over here where it says, can audio only interaction meet the requirements? So the answer is yes, yes, yes for a lot of these. That's why this thing about Medicare payment limitations on non-covered service. So that sort of confused me. So for any of our panelists knows exactly why they would add a non-covered service on here, let us know. And but this important here is they added a lot of yeses for telephone only for you guys. And they added the G0, 438 and 439. Those can be done as audio only as well. Again, we have the same issue that we have with other with this before, is how, even with videos, how do you take vital signs? How do you document? So panelists, do y'all have any sort of comments or questions about this particular document that came out that I'm not expressing?
Just to check it regularly. They change it a lot, just like everything else.
Yeah.
Keep adding to it. Good, but you know, we talk about refiling or adjusting and correcting claims. So every time they add stuff on here that could have been billed, you know, you just want to be ahead of it, because we've been flagging our system to identify, you know, what can be billed, what cannot be billed as telehealth, educating our providers. So the more you know it, the more you can educate, and then when you're going through your scheduling process, you can be more aware of what can or cannot be done as telehealth now, and incorporate that into the scheduling process. You just got to check it constantly.
Yeah. Yeah, it's probably a good idea to take this Excel spreadsheet and print it off and give it to your providers so they can see what services they can do via telephone or telehealth, and then work on your scheduling. Maybe have a staff meeting to go over, okay, what can we do? Well, we can do, you know, our G0438s via telephone now during this pandemic, so we can do that. And do remember, I didn't notice the status on here, I didn't mention that, but a lot of these will go away. There's about 85 codes on here that will go away once the PHE is over. So Doug makes a good point, is we'll look at this list quite often, because not only will it expand during the PHE, but it will go away once the PHE is over. So you just can't use the same list for, you know, the next year and a half. It's not going to be accurate. So anybody else have anything before we move on?
Mark, this is perhaps a technical distinction that's not totally relevant, but I think might be relevant eventually, especially if we get our way on the on changing the telehealth policy. But I don't believe that all these other codes are not, I wouldn't consider them telephone only. If you're doing all these other codes, including, I would say, G0438 and 439. Those are still technically audio visual. The only ones that are audio only are the 99441 through 3. And so it doesn't matter for RHCs because we bill everything as G2025, which is one of the weird things about us. But technically, you're not doing these other services if it's audio only. You're doing the 9941, 441, 442, or 443. Does that distinction make sense?
Not to me, Nathan, because it says on here, it's in the line, see the G0438 is in the column that says, can it be done telephone only? And it says that it can be. I mean, I don't know. I have a hard time figuring out how you do an annual wellness exam, an annual wellness visit, telephone, even doing telehealth. But according to this, is you can have a telephone only. Does any of the other panelists have a comment about that? Because I mean, they've really expanded the number of telephone only visits.
Well,
CPT use it.
You have to remember that annual wellness visit is not necessarily hands-on a patient. You would do that as part of a normal visit where I'm checking your blood pressure, I'm checking your temperature, all of those things. But it's developing their plan of care in a sense, is what do you want to work on and what are your risks and all of that. I think something else that someone else just pointed out to me as well is, when we're filing the annual wellness, normally for those, because it's preventative, it's paid at 100%, no coinsurance. So now I'm a little concerned because when we filed the G2025, is it going to process with coinsurance for an annual wellness visit? How are they going to know?
A good point.
Patty, Charles?
No, that's a good point. And I'm still concerned about your earlier comment about how are those preventive services going to get on that patient's common working file? How are they going to get credit for having those services? And then the cost share is another issue.
I think for those reasons, we can expect some more guidance as we refine this, I'm sure. And I think we'll just have to stay tuned to Doug's point.
Okay, this is sort of like watching.
You're right, Mark. I guess I didn't see the addition that I guess they did yesterday. There's a column can audio only, so I missed that. I'm sorry. You're right. So those can be audio only now.
Okay. Can you repeat that, Nathan? I didn't hear you the first time. What was that? You were what? You're what? I do that to my wife occasionally. About once in 35 years of marriage, my wife has said, "You are right," and so I tease her.
You're right, Mark. Yeah, sorry, I missed you.
Thank you. Okay. All right, let's move on. Like I said, this is sort of like watching sausage being made. If you guys, and we appreciate it. We still have 400 of you guys still on the line here, so we apologize for me taking up way too much time. Somebody asked this morning, so I'm just going to blow through these so Patty and everybody doesn't go away. We're assuming that counseling codes 90832 are not billable by telephone only. The answer is yes, they are. They're on the list there. It says yes, you can. So check what Doug said. Makes a lot of sense. Check this list and check it often. And then there is what will happen if you do a telephone only visit. Here's your code 99443. We're going to charge $100 for it. It's going to code, and this is from March the 1st. Remember in the documents there that this telephone services can go back to March the 1st. So if you're going to append or refile or whatever you're going to do to correct these claims, you're going to go back and look at your telephone only services, not your G0071s that were true virtual visits. But if you're really doing 99441 through 99443s back to March the 1st, that's when this started. You can go back and scrub your claims and look at them and figure out which ones were really telephone visits that you were billing as a G0071. And those are the ones that you want to refile or append or whatever you have to do to get paid. So that's your data service will go back to 3/1/2020, and it's going to get the same treatment as any G2025. You're going to put the CG modifier on it up until June the 30th. And then after July the 1st, it's going to work exactly the same way. In this case here, we had a 99441. We only charged $50 for it. We're still going to get the $92.03 for that. So let's move on here. The CS modifier is, y'all know me, I hate the CS modifier, but it was, here's the screenshot of what was in the document yesterday. Talks about how you can use it. One of the questions that I always have about the CS modifier, and let's go to it because I'm running out of time. The reason why the CS modifier is great is because the patient does not have to pay you guys any additional copay for that. And instead of getting that $69.05 that you got before, you're going to get your full rate, the $86.31 if you're an independent RHC. So if you can add the CS modifier and it's related to COVID, then that's something that you want to do. Here's just the who, when, what, and where of it, and the reference on where to look that up. I guess we'll end my section of it with this is one last panelist question is, again, listen to this office hour sessions is you hear different things. Some of the CS some people say the CS modifier is very narrow in scope, that you have to have a certain ICD-10 code on there. But when you read the language, it says that if it's related to ruling out a COVID-19 test, that you can include that CS modifier. So for our panelists, what should our clinics be doing on how should they use the CS modifier? Should they use with a broad stroke or should a very narrow stroke?
Well, I was looking at, this is a little different, but have you guys seen the thing about uninsured COVID-related claims getting paid at the same as the Medicare rate? It came out this week that part of that guideline, they had a few diagnosis codes that they considered encounters for suspected coronavirus. And I was thinking that if you had that same set, and there was about 5 or 6 different ICD-10 codes, that kind of is what qualifies it for something like that, and maybe also the usage of this CS modifier, kind of using a diagnosis code to show that you're doing something to treat either someone who has it or you're suspected of it.
Okay, and that makes sense. So it's a very, you got 5 or 6 ICD-10 codes that if that patient has that, then those are eligible for the CS modifier. Is that what you're saying, Doug?
That's what that's the way we're looking at it.
Okay.
So, Mark, I think there's some CDC guidance on which ICD-10 codes to use.
Okay.
I might could find the list here.
Yeah, Doug, if you want to send those to me, or Patty, if you want to send those to us, we will definitely share those in the group there so people will know when it's appropriate to use it. I know on the office hour session, they read very broadly because they want to be able to use it, while CMS typically says, no, you can only do it for certain ones, which I think what Doug had said and what Patty are referring to as well. So let's go questions. Listen, that means it's time. Patty, I'm going to turn this thing over to you right now and make you the presenter. And I apologize for taking way too much time, but I think like I said, we were making a little bit of sausage there, and I think some of that stuff was very helpful to people. So Patty, go ahead and take over for us. We appreciate it very much.
Okay, I'm just going to hit some broad points, guys. These are some slides that you may have seen before, and we're not going to go over all of them, but I think most of the questions have been about documentation requirements, particularly how to capture vital signs. And so I've added some slides to this presentation that may help with that. So we want to document, we still want to document with telehealth services or virtual services. We still want as much clinical documentation as we can to support and differentiate between the type of service and the level of service that we've done. And if you can work with your EHR, like with Azalea or with Aprima, if you can work with your EHR on those, you need to. If you don't have a module that you can be using right now, you need to be creative and come up with some documentations. Stop and start times are going to be important, again, for determining the level of the service and documenting the provider time. Whether or not your EHR is going to be able to take those start and stop times, or your paper note is going to be able to take those times and translate them to something that your cost report preparer can use, that may be a whole nother issue. And I'm just going to kind of skip ahead. It's very important that these records, especially if they're not tied in with your EHR, that you have really prompt completion of records, that we don't leave those things out there, because the telehealth visits and the virtual visits, we have less in our mind to tie us to those, since we didn't actually physically interact with the patient. So I think it's important to be timely with that documentation. CMS doesn't have any particular guidelines. If you've been on the office hour calls, they get a lot of questions about documentation for phone calls for the preventive services. So what I'm going to show you are best practices. MGMA has these best practices for documenting a telehealth service, and the link is at the bottom of the page. And then AHIMA, who is the health information management folks, they have a little bit lengthier documentation guidelines for telehealth. And so these are best practices guidelines. They are not anything that have come to us from a regulatory compliance standpoint or guidance standpoint. So most people agree that there needs to be a two-step process. So the provider decides if a telemedicine or a virtual visit is appropriate, and then that service is scheduled. And so it's between that time of it being determined that it's necessary and the scheduling that we might be able to obtain consent under general supervision. And so it's usually a two-step process. And then the provider is the one responsible for documenting their service. And so this slide and the next slide are AHIMA's best practices. So one thing that we've done on our paper note that I'm going to show you in a minute is we've added a few places to document some of these best practices, such as the location of the patient and the location of the provider. So we know that we don't have restrictions on that right now during the public health emergency, but when we're getting used to telemedicine and we know this is how we're going to go forward with things, we need to get in the habit of documenting as accurately and as completely as we can. So again, we have MGMA best practices, we have AHIMA best practices. Those are just two examples for you to use. These handouts are over in the handout section of the webinar panel, and they also can be available to you if you reach out to us for those. And here again, more of AHIMA's. So MGMA was really short with 2 little paragraphs, and AHIMA gave three long recommendations. I have had health information management directors reach out to me and ask why not everything they're seeing goes by AHIMA's guidelines. So just know if you get a question, it could be because those health information professionals are expecting AHIMA's guidelines to be followed. And there is a toolkit available from AHIMA, and the link for that toolkit is at the bottom of this slide. So you guys have probably seen this before. We are offering this paper note free to anybody who wants it right now that may not have EHR capability right now. So these are some of the things we're going to want to capture: the patient information. We're going to want to capture the provider. Now that we have expanded provider types in the rural health clinic, we may want to capture what that provider's credential is. Is that a physical therapist? Is that a dietitian? Is that an LCSW? Is it an MD, a DO, a nurse practitioner? We may want to capture that. Also, we want to capture the patient's name, their date of birth, some patient identifiers. If we have a minor patient, the best practice is that the parent or the guardian be present during the telemedicine visit. So we have made it really easily where you just check that box. Also, you just have check boxes for verbal consent obtained and for acknowledging that maybe a HIPAA non-compliant HIPAA method was used. So we can document all that in the top part of our note, along with the type of this service that we've provided. We've also modified this note to actually list what application was used. That may be helpful when we're going back and deciding. And then we know with our telemedicine visits, we will have COVID visits, COVID related visits, but we will also have other visits, anything on that approved list that we've been talking about. So any other acute condition or chronic condition. And then we have added on this note the location of the patient and the location of the provider in accordance with AHIMA's guidelines for the documentation. So this might be the things that we want to capture, make sure our EHR is capturing, make sure that we are tracking the types of services by which providers, so that we have that data when we come to having to carve some of this out. If we move along, we want to collect as much history of present illness as possible because we're going to be heavily reliant on the patient or the historian for most of this information, since we will not have an actual physical exam. So we have added a section to our note. You can see I have a yellow box around it. It's vitals per patient or historian. Because we're just going to have to capture that information as history of present illness, and we might want to refer to that patient's medical record for what their past history has been on constitution and vital signs. But we're going to have to rely heavily on the patient as the historian and the history that they give us. As far as the annual wellness visit, if the patient weren't in the home, if the patient were in another originating site, we might have a telemedicine presenter there that could actually take these vitals. But if this is a phone call only, the patient is in their home or they're in their home, we aren't going to have a way to objectively capture those vital signs. So it's going to have to be part of history. Then we want to go on just like we do in a regular note to the, if we were having a SOAP note, we would have an assessment and a plan section of that note. So we also want to include that. And then just for easy sake, we've made some check boxes for whether we had to order the COVID screening test, whether the patient was sent to the emergency room, did our service with that patient result in a prescription being ordered or a prescription being refilled. So we've just tried to capture everything. Now, if you have an EHR, you won't need this kind of paper note, but I think it also helps to visually see what some components of documentation would be. And so we will make this paper note available to anybody who will message me on the Facebook pages or email me. We'll be glad to share that. And we have revised it. We started making this note like on March the 7th. And so this note has been revised 3 times, just like all of our other slides and our billing guidance have been updated over the time that we're doing it. Okay, I got this question yesterday 3 or 4 times. Just because we have G2025, G0071 is still a valid code. It was a valid code before COVID. It's going to be a valid code after COVID. It's not going away. So there are still services that we could be doing that we will be capturing and reporting with G0071. And the reimbursement for that code during the COVID emergency has been increased to $24.76. That reimbursement will revert back to about the $13 that we were getting before the emergency when we're done with this. So this is the code that we would still use for certain e-check-ins, certain e-visits, G2010, G2012, the 99421 through 99423 codes. So these are technology assisted services, digital e-services, such as what Charles mentioned, secure text, patient portal, that brief e-check-in to see if the patient needs to come in, which would fall short of a regular telephone-only evaluation and management. So G007 is not going away. G0071 is not becoming another code. What we see in the guidance that we got yesterday, though, is the telephone call codes that we were assuming went under the G0071 umbrella are now moved over to that other side under the G2025. So we still have virtual communication services. You still may want a way to track these services or track claims on hold or track claims that you've adjusted. So you can simply do that with a spreadsheet type tracking if you're not able to do that within your system. We do know, this is old news, this has not changed, that if we're using a communication method that is not HIPAA compliant, that the OCR is going to turn a blind eye to enforcing those violations. They're not waiving them, they're just not going to enforce them. So there again, make sure on that note that you make sure that the patient is aware of whether you're using a HIPAA compliant method of communication or not. And same thing we've talked about before, we can use FaceTime, we can use Messenger, but we can't use anything that's publicly facing like FaceTime Live or any of those things that would be broadcast to the whole world that are public facing. Okay, and these are the compliant, HIPAA compliant communication products, platforms. I just want to say during telemedicine, we're getting used to this. During a public health emergency in very small towns or rural clinics, it's very easy for us to say, oh my goodness, Mrs. Jones came in today and her test was positive. So we need to make sure that the need to know rule still applies during a public health emergency. The only time that we can disclose things are when we're disclosing these cases to public health agencies and to other agencies and law enforcement agencies if there is a risk of harm to people. And then we need to be concerned about the security of our computers at home with everybody working from home. And so we're going to have PHI up on our computer screens as we're working. We want to make sure that we don't leave those screens up. We don't have unauthorized access from people while we're all working at home. I think we talked about this last time and this hasn't changed. I think this is something that Kate Hill's been really good about reminding us of, that we are all in a live emergency plan activation. And so you need to be keeping up with what you're doing, because what we did on March 7th is not the same thing that we were doing on March 15th, is not the same thing that we were doing on March 20th. So this has been a progressive response, where normally our emergency plan response is just a very small window of hours or days. We're into week 8 or 9 now. And so another thing that we have prepared is an emergency plan activation document to help people document what they've done. And we also would make that available to you if you would like that. Just let me know your name, your facility name, and your location, and we will get any of our Inquidocs library items out to you to use during this time. And you've already seen that picture, so I am ready to give it back. I'm going to give it to Julie. Is that right?
That's right.
Okay. Change presenters to Julie. Thank you, guys.
All right.
Thank you, Patty.
Okay. So now you see my screen, but I can't see you guys. So if I do this, can you still see my screen, or do you see all 4?
We see your screen and we see all 4. So we're good to go.
Oh, nice. Okay. So I'm going to kind of bounce back and forth just so that I can be sure that I'm not, showing you the window behind me with all of the glare or anything like that. But basically what I want to do here today, because we are way over time. So these are a lot of the same slides we went over before. If you did not listen to it the first time around, what I'd like for you to do is go listen to it on the recording. I'm not going to go through this piece again. Again, in its simplest form, RHC cost divided by visits equals its rate. We have to put the telehealth down in the bottom, and that non-RHC, it allocates overhead. Again, those elements we're not going to go through today. We don't have time for that today, but we went through those in detail and they will be on the recording. Mark, is that recording available, I guess, online?
Absolutely. We everything is on ruralhealthclinic.com at COVID-19. So all of our recordings are on there. Some, like I said before, most of them probably the billing advice ignore, but just fast forward to where Julie talked about cost reporting. That will mainly be the same.
Good, good. Okay. So basically what I want to talk about here today is the fact that, let me make sure I'm back here. How are we going to do this? What changed with this? Well, if you're going to do actual time, there's two methods for calculating the carve out that goes down into that telehealth cost center. In my opinion, there may be some other more creative methods, but I've tried to boil it down to the top two, and that is actual time spent. If you want this tracking log, let me know. I can send this directly to you. I think Mark also has it on his website, where you actually time in, time out, make sure you include charting time, tell us what you did. And then we can use that on the back end as we do the cost report carve outs. The other, when we talked the other day, we talked more about using CPT codes, extracting CPT codes from your system. I'm not sure if every system is going to be able to do that with the new G code that they've put out. It sounds like, I don't know, Doug, don't know, Doug, if you're still with us, that Azalea has a way to, on the back end, say, of those codes, this many were level 2s, this many were level 3s. If you have a system that can extract that data, I think that we can very easily calculate what that carve out's going to be from that data. So you're going to either have to keep logs, or you're going to have to work on the back end to be sure that you can produce a report that's going to say, we did this many 5-minute calls, we did this many 10-minute, we did this many 99213s, 45s. That's where we were a week ago. We thought that was our kind of fail-safe, our backup. And I think there are going to be some systems that are going to be able to do that. But if you can't, keep this log. The other thing that I wanted to talk about here is when I said use, as far as method B, because method A is actual time spent, where you just really are diligent. And I have one of my star students on the line, and I won't even mention her name. You know who you are. She's been keeping this. Her folks have been doing this, and I'm going to get a log of every telemedicine visit that she in her clinic does. There are others a little late to the game. Maybe your providers aren't all on board and you don't have this log for everybody. If you don't, maybe you can get that log done partially. As far as the Medicare regulations go, it's 1 week per month, can't be the same week every month. When they're talking about base time study regulations, Mark can attest to that. It's just old school minimum time studies. So we can apply that a little bit and say, okay, if you don't keep up with it all the time, at least keep up with some of it. And maybe we can extrapolate that and say, in a normal week, we did this many 5-minute, we spent this much time and do those carve outs. Takeaway from this is keep a log if you can. Get on the phone with your cost report preparers. And I cringe when I say that, because I'm going to be talking to a lot of people over the next several weeks on what are we going to do? How are we going to do it? Talk to your back end folks with EMRs to see what can they pull timestamps? Can they tell you the time? Are they that sophisticated? And work with the folks now to see your cost report folks to know what kind of data you can be capturing for them to do a carve out on the back end. And the back end is going to carve out direct time spent doing telehealth. Remember, back from our slides up here, get back over there, back from our slides here, we only pull direct time down in that non-RHC cost center. The overhead will allocate itself on the cost report. And that's all I have. I just don't want to belabor that anymore. If you want to go and listen to the original presentation that kind of goes through all of the logic behind that. The changes for today is get with your EMR vendor. It sounds like Azalea's got something that is going to create that. Keep a log, keep a partial log, start it now. Some information is better than none.
Thank you, Julie. We appreciate it. I tell you what, we are really, and I apologize. It was my doing. I'm the one that got so far behind on time, and we just had so many issues in the panelist session. I think it worked really well for us to go through some of those issues. Unfortunately, I think the only thing we determined was it was okay to drink during work. The other things that we have to do are there's still a lot of unanswered questions. So maybe our best bet to do is, as much as it's sad to say, is maybe come back in a week or so when Shannon's got a home. She's going to run over there and do her thing at Palmetto and find out some things for us. And Doug, if you can help us out on this one, because you're the CPT master and all that, and maybe know how to append and all these sort of claims, is maybe we can put together something whenever we get some answers for you guys later on. And put together and come back and do another webinar for you guys, because you've gone 2 hours. You guys have been wonderful for hanging around. We still have a lot of people still left over at this time. So if y'all want to, Doug, do you have anything? I know we didn't give you a chance to sort of talk a whole lot during the session, but do you have anything to help us as we sort of end this session?
No, just I have all these things bookmarked, and I would recommend that as well. So like a lot of I have y'all the HBS website bookmarked with the resource page, that telehealth list bookmarked. We even set a calendar reminder for certain times to recheck things. So I would definitely recommend that, because stuff is changing so often. And then when you have to go back and make corrections on claims, the sooner you know what the changes are, the better. So I've got a really long bookmark list of just COVID-19 related web pages that I reference on a regular basis.
Okay, Shannon, we didn't give you a chance to do your a presentation either, but do you have any final words too before we sort of close down the session?
No, I'm good. I think that this was fabulous. I think we'll get a lot of additional information from CMS and or some of the individual MACs, and of course we'll share that information. And if anyone has questions, I know every single one of us will take those emails. So thanks for letting me be on.
Thank you very much. Thanks to all the panelists. I know. Thank you, Charles, Patty, Julie, Nathan, and Nathan. I guess he's still on the line here. Nathan, I'll let you send us out with some marching orders to go and politic for our rural health clinics on phase 4. Do you have any final marching orders for us for what we need to do to support rural healthcare before we go?
Obviously, I highly encourage all rural health clinics to contact their federal legislators. There'll be more detail when and if that legislation that I floated is introduced. I think it might be called the Improving Telehealth in Medically Underserved Areas Act or something like that. So just be on the lookout for that. We need grassroots support if we want to fix these telehealth issues. Thank you all.
Okay. All right. Well, thanks to everybody. We're going to close down, and we will. Unfortunately, I think we may see you next week. So, all right. You have a great weekend, and we certainly do. From all of us, we do absolutely appreciate you people that are on the front lines and fighting this war. You are the heroes. So, thank you very much, and we'll do our best to be the butler to support you guys while you're Batman. So, thank you.
Thank you.